Great. So from something that was quite useful to something that's completely useless, because you've all had this already. So this talk was on what are the right surgical margins. So it's a brief talk just to explain the changes over time that have happened to surgical margins. I feel the world has gone upside down because the surgical talk has no gory slides in it whatsoever. I feel I should trudge out and leave. But anyway, so historically, if you go back to many years, melanomas were taken out with a 5 centimetre margin. And you can imagine what a 5 centimetre margin, so 2.5 inches, all the way around the scar looked like back in the 70s and 80s. And then there were various trials that were done over the years, and then 5 centimetres became 3 centimetres. The biggest margin that you would ever have would be a 3 centimetre margin all the way around the scar. And so what I mean by that is, if you look here, this is a 2 centimetre margin all the way around the scar, and then you then have to turn that into an oval, or what we call an ellipse. If you imagine that being 5 centimetres all the way around the scar, or even 3 centimetres all the way around the scar, then you realise you're making considerable defects. Mostly people ended up with skin grafts after melanoma excision. And there have been some sort of what we call keynote studies over the years, and the biggest one was compared basically a 3 centimetre margin with a 1 centimetre margin, and essentially it boiled down to you maybe didn't even need to do a 3 centimetre margin. So something less than 3 centimetres was good enough for melanoma excision. So, and then anyone says, well, how deep do you go? Well, we have this great saying, it's called down to the next fascial plane. And I think it's called doctors know what the next fascial plane is, or they should do. And essentially, most of the time, it's wherever you are around the body, you've got skin and you've got fat, and then a lot of places you've got this superficial fascia. That's a little bit hard to see sometimes. But what you have is this. You also have a lining of this fascia, which is, you see it on beefsteak. It's the clear, sinewy stuff that lies on top of the steak. And we have that on our muscle. And essentially then, if you say you'll go down to this sinewy stuff on top of the muscle, that's called the fascial plane. And it's what it means that what it's trying to make your doctors do is take enough tissue underneath the skin to make sure it doesn't come back. So the rule is the next fascial plane. Now, some parts of the body, this is really obvious, and that's about 3 centimetres in anyway. If you come to my tummy, the superficial fascia is 3 centimetres in. That's plenty enough. But most people will go to this sort of deep stuff, this sinewy stuff on top of the muscle. So that's how deep you go. As we'll discuss later, just think about the different parts of your body. I mean, how deep do you think the next fascial plane is on your cheek? Or how deep is it on your foot compared to your tummy? So you can see there's a lot of variation. One area you'll take 3 centimetres deep, one area you'll take 2 millimetres deep. So there's no magic science in this. But what I will say is that in 16 years, seeing melanoma coming back underneath the scar, so actually in the fascia, if you like, or left on the fascia, I mean, it must have it's a handful in all my career. So melanoma, if it comes back, tends to come back on the skin spreading out rather than necessarily underneath where you've had it removed. That said, I'm going to get a few hands going, oh, that's not my thing, but I think it's unlikely. So, well, what are the rules? So this is the current NICE guidance, NICE UK guidance. I think I should probably say, just to follow on from Andrew's talk, if you see something suspicious and your doctor thinks it's melanocytic or it's related to, could be dodgy mole type of territory, then we would take it out with a 2 to 3 millimetre margin. People shouldn't be doing incision biopsies. And what I mean by that is, if you think that something is a dodgy mole, you shouldn't be taking a little bit out of it, because that disrupts everything. There are a few exceptions. The basic rule is, if you think it's a dodgy mole, you should be having it removed, sent away for analysis to determine if it's a dodgy mole, and then if it's not, you've had it removed and your 2 to 3 millimetres is enough. If it is, then you then find out what it is, and you plan the treatment afterwards. So this is the NICE guidance currently. So melanoma in situ, that's the precancerous stage. And I like to describe that as when all the cells look like melanoma cells, but they're all sitting in the right place in the skin. None of them have moved away. They're all still there, but they all look dodgy. So that's what we call it, melanoma in situ. That's hard, so you take 5mm margin, that's a cure, that's enough. If you came with that, you'd have that removed, you'd be discharged. So we could talk about stage and stuff, but basically if your melanoma is less than 2mm or then you would end up having a centimetre margin. That's what NICE recommend, but not if it's between 1 and 2mm with ulceration. And I'll talk what I mean about ulceration in a minute. And if it's greater than 2mm or 1 to 2mm with ulceration, they recommend a 2 centimetre margin. So as you can see, 1 to 2 centimetres. This is what I mean by ulceration. So I describe it as a volcano. So what ulceration means on your pathology is that basically the top has been rubbed off or has eroded off or has been knocked off or has just died. So probably the thickness or the height of your mountain was more, but the top's gone. So therefore ulceration at whatever level makes your melanoma more significant. So that's essentially what your melanoma looks like. So that's why the ulceration makes a difference. But you had those talks yesterday, didn't you? Okay. I'll shut up. So this was a very useful paper. Dr. Fong, he looked at all these are the differences. So the National Comprehensive Cancer Network, the Cancer Care Ontario, Canadian Medical Association, Europeans here. And so for the different LEPs, in situ everyone agrees, 5mm. Sort of thin melanomas less than a centimetre, less than a millimetre in thickness, a centimetre, so everyone's happy with that. Then, broadly speaking, between 1 and 2mm in depth, you take between 1 and 2 centimetres, probably depending on the ulceration. And then once you get 2 to 4, everyone's, well, the Australians are, hey, do mate, take a centimetre out. But the Australianist, I mustn't be that. But everyone else sort of about 2 centimetres. And then over 4mm, all of this group still say 2 centimetres. So you can basically say, well, this is and the Dutch are the same. So the Europeans, the Australians, the Americans all say that 2 centimetres, the first picture I showed you, is probably the widest margin you need to go to. But there's a little room for manoeuvre here. Does that make any sense? So this is the UK melanoma guidance. So we're still for the thicker melanomas, we're still being told to consider a 3 centimetre margin for the thicker melanomas. I think that may change, but that's currently where we are. So nowadays, if you've got a thicker melanoma in this country, they will be considering a 3 centimetre margin. For everything else, pretty much it's 1 to 2 centimetres. So one of my colleagues, now a professor of plastic surgery in Norwich, someone called Mark Moncrief, has been trying very hard to get a trial organised. And he's done all the research. He tried to get it through, asked the NHS to fund it, asked the NCRI to fund it, and no one would fund it in this country. Basically comparing whether we actually need to do any more than a 1 centimetre margin for any sort of melanoma. The risk of upsetting oncologists, there might be the odd one left here. So it is extremely hard to get any surgical trials in this country funded in any way, because this is all things that improve quality of life. So we've got various trials on groin dissection, make them better. There's no funding for quality of life trials. You have to have survival benefit. And this was a trial, but this was put together by a very clever person who researched it for 10 years, put it through all of the big organisations. They turned it down. So he's went to Australia, who funded the trial. They funded the initial trial. And so this is up and running now. We've done the first 400 patients. So Oxford, there's a lot of places here. We're all part of that. And it's basically to comparing for any melanoma greater than a millimetre, you take out 1 centimetre, you take out 2 centimetres, and you're looking to see what the recurrence rate of melanoma is if you take out 1 or 2 centimetres. Pretty straightforward, really. It's a surgical trial, simple. The other thing is we don't have drug companies that have got lots of things to sell either, but that's another aside. And then they're also looking, well, if you get an increased local melanoma recurrence, does that affect any of these other things? So it might come back, but does it actually affect any of the outcomes? So we're waiting to see if the full trial is going to get funded. But that 1 centimetre is a big difference around our bodies to 2 centimetres. As I can tell you from a surgical perspective, 2 centimetres, particularly if it's been taken out in slightly the wrong way initially, means you're ending up with grafts and flaps, whereas 1 centimetre you can pretty much get away with stitching it up and relatively low, what we call morbidity or downsides. Here we go, for the ladies. I found something on the internet. My wife's got me watching Love Island now, so I'm sitting there with a duvet up going, you serious? Anyway, for the ladies, but this is the rub here. So a melanoma here, even if it was 4.5 millimetres thick, you wouldn't be taking a 2 centimetre margin, because you wouldn't take out the eye, you wouldn't take out the eyelids, you wouldn't take out the nose. So on the head and neck, pretty much the only margin you ever get is a centimetre, and because the fascial plane is about 3 millimetres deep, or 4 millimetres on the eyelid or in this area, you don't get a very deep margin either. And we will be publishing some results of this, but we've just looked at our earlobe melanoma in Oxford, so that's very small percentage of people, so only 43 or 44 people who've all had a sentinel node biopsy, and our local recurrence rate is nil in 15 years. And that's with all the survival data as well. And we're not taking any more than a centimetre off anyone's ear when we do that. And in fact, as we will also publish, we don't even do wedge excisions. We just say, well, this is skin. The next fascial plane is actually the lining of the cartilage. So we take it off and put a skin graft on. So from our experience, probably less is fine. But I must counter that by saying there are bigger studies around the world that have suggested that the local recurrence rate will be more if you take a lesser margin. So there are other countering views to that. But the only way to find out is to run a trial, and that's what we're trying to do. So if you spot any dodgy moles on your follow-up and your checkup, and we'll talk about how you do that in a second, and I'm nearly finished. And I think that I actually think that people who've had melanoma are pretty good at spotting things, and they're also very good at saying, I go, well, I don't think that's anything. They go, it's done exactly the same thing as the mole I had first time, and I went to my doctor and he said it wasn't anything. I go, all right, I'll take it off. So I think people become very aware and they become very wise about what they're looking at, but we'll discuss that a little bit later. So what is the right margin? I don't think it's any more than 2 centimetres wherever it is. I think maybe we'll find that lesser margin is okay, depth down to the next fascial plane. I think that's it. Okay.